You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology. And this is This Week in Cardiology for May 2nd, 2025. This week, I'm talking FDA approves TAVR in patients with asymptomatic aortic stenosis, a digital health topic, subcu ICD versus transvenous ICD, and stroke in young adults. Edwards Lifesciences, the maker of TAVR valves, announced that the FDA has given approval for TAVR in patients with asymptomatic aortic stenosis. FDA has based this approval on the early TAVR trial, which I think is one of the most biased studies I've reviewed in the last 2 years. Only the option trial outdoes early TAVR for bias. I worry that this FDA approval will lead to a serious increase in TAVR procedures in patients who A, could wait, and B, might be better off with surgical aortic valve replacement. I will do a brief recap on early TAVR because it's instructive on how trials can be designed in such a biased way that they guarantee a positive outcome. I wrote about this trial in November of 2024. Early TAVR compared two strategies in patients with severe but asymptomatic aortic stenosis: TAVR right away or clinical surveillance. Of course, the trial was unblinded. Patients knew their treatment assignment, so patients in the control arm or clinical surveillance arm knew they had severe valvular heart disease and did not get any treatment. They had classic subtraction anxiety, like the medical treatment arm in FAME2, which was PCI versus medical treatment. The primary endpoint always matters in a study, but it matters a lot in unblinded trials. In early TAVR, the primary efficacy endpoint was a composite of death, stroke, and unplanned hospitalization for cardiovascular reasons, and that's a key component. Patients in the trial were 76 years of age. On average, 30% were female, and most notably, they had low surgical risk. Over a median follow-up of 3.8 years, the primary endpoint occurred in 27% of the TAVR group versus 45% of the clinical surveillance group. That hazard ratio was 0.50, and the confidence intervals were highly significant. Individual components of the composite tell an important story. Death was not significantly different, 8.4 versus 9.2%. Stroke was also not significantly different, though it was numerically lower in the TAVR arm, 4.2% versus 6.7%. The driver of the lower incidence of the primary endpoint was lower rates of unplanned hospitalization for cardiovascular reasons. In the TAVR arm, it was 21 versus 42% clinical surveillance. That hazard ratio was 0.43, again with highly significant confidence intervals. In the paper's main figure in the New England Journal of Medicine, the Kaplan-Meier curves for unplanned hospitalizations and the primary endpoint was nearly superimposable. So in other words, it was nearly all driven by unplanned hospitalizations. In the surveillance arm, conversion to TAVR occurred rapidly and steadily. More than 1 in 4 surveillance patients had TAVR before 6 months, nearly half at 1 year, and 71% had TAVR at 2 years. The reasons for conversion to TAVR in the surveillance arm was almost always progressive symptoms and signs of aortic stenosis, not acute decompensation. Now, you doubt me. You read the Edwards press release where the PI of the trial, Dr. Philippe Genereux, said the following, quote, "As we saw in the early TAVR trial, patients originally designated as asymptomatic became symptomatic in sudden and unpredictable ways, underscoring the importance of early evaluation by a heart team to improve patient outcomes and benefit the healthcare system." I would counter that enthusiastic comment by saying that A, there was immediate separations of the Kaplan-Meier curves of unplanned hospitalization. Now, why would patients report no symptoms, pass a stress test, and then have an immediate spike in hospitalizations? My second counter was that patients in the control arm that converted to TAVR did so not because of acute problems like decompensation, but because of new signs and symptoms. just as occurred in the FAME-2 trial where patients who had a significant coronary lesion and were not stented presented for urgent revascularization mostly because of symptoms, not any objective signs. What's more, early TAVR also found no significant differences in death or stroke. If not for the inclusion of unplanned hospitalizations in the primary endpoint, clinical surveillance would have performed similarly to TAVR. If that was the case, there'd probably be little enthusiasm for early intervention. The old way of active surveillance would have been confirmed. Looking at hard endpoints, I see no penalty for waiting. A final criticism of the early TAVR trial was the lack of a surgical arm. These were relatively young patients with low comorbidity, low surgical risk, who, if not for the trial, may have been better suited with a surgical aortic valve replacement. Early TAVR was designed to get a positive result and sell more TAVR valves. FDA should have stood strong. It's disappointing. And while I believe there are patients with severe AS who are labeled as asymptomatic, but are only asymptomatic because they have gradually reduced their physical function due to dyspnea, and these patients should actually have AVR, early TAVR trial does not sort these patients out. More than 90% of the patients in the trial had a reassuring stress test before study entry. They had no symptoms, no angina. They had decent exercise capacity without drops in blood pressure or significant ventricular arrhythmias on the stress test. Then they were randomized to get nothing, while the others had AVR. To absolutely no one's surprise, they soon had symptoms and came to the hospital, thus driving the trial to be positive. Now FDA approves the TAVR for asymptomatic people, and people will get operations based not on symptoms, but shadows from the ultrasound. I know some people will object to me calling echocardiography shadows on an ultrasound image, but I want to say that the judgment of severe AS is not always so super straightforward. My friend Anthony Pearson, the skeptical cardiologist online and a noted echocardiography expert, has told me that measuring severe AS can be difficult and requires really significant care and expertise. So I wonder how many patients will be operated early for asymptomatic AS who don't really have severe AS. Okay, next topic is a story about PPGs that can distinguish the source of tachycardia. While many people are buying smartwatches and portable ECG recording devices, the vast majority of digital heart rate devices are PPG or photoplethysmography. My low-end Garmin watch is a PPG, for instance. It records a pulse using some sort of optical methods. I know, I am a doctor, not an engineer, but one of the key things we learn in medical school is to differentiate VT from SVT, because in some, but not all cases, VT has a more ominous prognosis. I found this week via Twitter a study in the commonly read journal Computer Methods and Programs in Biomedicine, which uses machine learning to sort out the origin of a tachycardia from the PPG signal. Lead author Martin Manager and his colleagues, mentored by Dominic Lins, described this elegant study that even an AF ablation doctor can understand. They had about 30 patients who had an EP study for tachycardia, and they also had them wear a PPG wristband. During the EP study, you pace both the atrium, which most often leads to a narrow complex, QRS, and the ventricle, which is a wide complex, QRS. Their EP studies yielded about 25,000 samples, which the authors split into a training, testing, and validation data sets to do the machine learning. Now, on an independent patient level, correct prediction was possible only 73% for atrial pacing and 59% for V pacing. This is from the PPG. But with adaptive performance built on previous patient-specific annotations, this classifier, this model, correctly predicted the origins of a PPG-derived pulse wave in 97% for A pacing and 95% for V pacing. Now, normally, on TWIC, nearly all the studies I present, I can tell you about the study procedures and methods, but I won't even try in this case. The authors show an example of an annotation from the PPG, and gosh, they look similar to me. And I certainly don't understand convolutional neural networks, machine learning, or any of that business. I tell you about this paper because it's cool. A few years ago, I would have never imagined being able to record a heart rate from a wristband with an inexpensive watch. Back in the old days, we had the chest bands. Now, I would not have imagined being able to sort out a ventricular from an atrial source of tachycardia from a pulse wave. This study doesn't tell us how to take care of patients, but it's a nice piece of science. It's also limited to a controlled setting in patients in the EP lab, so there is still a lot of work to do. But yet, it's hard to imagine where we'll be, right? What was the practice of medicine like before the internet? Being able to detect VT from SVT with a PPG is just amazing to me. All right, next topic is more related to patient care. This is the Pritorian XL trial. At the Heart Rhythm Society meeting and in the journal circulation, we heard the results of the Pritorian XL study. This was a 4-year extension of the Pritorian trial of the SICD, subcutaneous ICD versus transvenous ICD. The study is highly problematic, and it has many lessons about how bias seeps into the medical evidence base. But first, some background, because there is plenty of bias there too. The question of what ICD to use in a patient is an important one. The traditional transvenous ICD has been standard for decades. The leads go into the veins and they go into the heart. Since they are in the heart, they sense and pace quite reliably. But since they are in the venous and cardiac system, they are also susceptible to serious infection, which can be deadly. And over time, intracardiac leads can develop problems, just wear and tear. Subcutaneous ICD use a lead outside the ribs in close proximity to the heart. The generator is off to the side of the chest. The advantage of the SICD is that lead infection is rare and less dangerous. The disadvantage, of course, is that there's no pacing, and having a lead not in the heart, but around the heart, creates sensing issues. The phrase sensing issue belies the severity of this problem. Sensing issues means the device can double count R and T waves. So just walking up the stairs, a sinus tachycardia of 120 becomes 240. And if your heart rate is 240, inappropriate shocks can occur, and inappropriate shocks are terrible. No, they're really terrible. Back in 2020, New England Journal of Medicine published the results of the Pritorian trial. This was a non-inferiority test of subcutaneous ICD versus transvenous ICD. More than 800 patients with an ICD indication but no need for pacing were randomized to either device. The primary endpoint of device-related complications and inappropriate shocks was a composite. Device-related complications and inappropriate shocks occurred at rates of 15.1 versus 15.7 in the SICD and transvenous ICD group, respectively. The hazard ratio was nearly 1. It was 0.99. And the upper bound, or the worst-case scenario for the subcutaneous ICD, was 1.39, or 39% worse, and this was just under the agreed-upon non-inferiority margin of 1.45. Now, as you can imagine, the two parts of the composite primary endpoint went in different directions. This is an absolute flashing red light for non-inferiority studies because when you test non-inferiority, if you have endpoints expected to go in different directions, they can cancel each other out and limit the treatment effect size differences and then make no difference. So device-related complications such as infection, bleeding, lead revisions, etc. occurred 31% less often with the SICD, but inappropriate shocks occurred 43% more often with the SICD relative to the transvenous ICD. The authors declared the SICD non-inferior to the transvenous ICD. Marketing then ensued, and there was a period of irrational exuberance for the more costly, new, and fancy ICD. Like Watchman and left atrial appendage closure, being an SICD implanter brought status to you in the field. The capital T, capital P top people were SICD proponents. Before I tell you about the highly problematic Pritorian XL study, I need to tell you what I believe are the fatal flaws in the original Pritorian trial. First, as identified in a letter to the editor from the McMaster Group, the design was not appropriate. When you study non-inferiority, you test whether a new therapy is non-inferior for efficacy. Then you must show that the new therapy is superior for safety or it offers something more convenient. Aristotle, for instance, apixaban versus warfarin was a classic example. It showed that apixaban was non-inferior to warfarin for stroke prevention and superior for safety. It is highly problematic to study non-inferiority with a composite endpoint that includes efficacy and safety. The best example is the Prague 17 trial of left atrial appendage closure versus DOACs, where thrombotic effects like efficacy and bleeding safety go in opposite directions, resulting in a canceling out and no difference. And recall that in non-inferiority comparisons, no difference is a, quote, positive outcome. And this is exactly what happened in Pritorian. By having an endpoint with two components going in opposite directions, device complications and inappropriate shocks, the authors made non-inferiority easier to reach. A better design would be to show non-inferiority in efficacy, something like shock efficacy plus mortality, and then you have to show superiority for safety, such as inappropriate shocks and complications. All right, second problem with Pritorian. Rita Redberg, Bogdan Inaki, and I co-authored another letter to the editor in New England Journal of Medicine on Pritorian. We identified a problem with counting appropriate versus inappropriate shocks. Now, in the trial, of the 83 patients in the subcutaneous ICD arm who had shocks labeled as appropriate, 11 had shocks for VT below the cutoff of 180 beats per minute solely because of oversensing of cardiac signals. For example, ventricular tachycardia at a rate of 150 beats per minute could be sensed as 300 beats per minute. Now, such an event is clearly an inappropriate shock. Recall that in the main trial, non-inferiority was barely met, right? Upper bound was 1.39, non-inferiority margin 1.45. So we estimated that had even half of these 11 shocks for double-counted VT been labeled inappropriate, the Pritorian trial would have failed to show non-inferiority. And here is the best part. The Pritorian authors must have once agreed with us that shocks for double-counted slow VT were inappropriate because in their original protocol, before they changed it, they had appropriate shocks defined as VT greater than 180 beats per minute. And in a previous observational study, many of the same authors called shocks for slow VT inappropriate because they are both painful and associated with increased mortality, right? We have the Made It RIT study, which showed that permissive programming, which reduces shocks, improves mortality. Thus, the evidence base for SICD versus transvenous ICD rests on very, very shaky ground because of these problems with Pritorian. Now let's go to the Pritorian XL study, which had a great idea of following patients in the trial for an extra 4 years. That would be a total of 8 years. And I call this a great idea because in real life, ICD choices have implications for years and even decades. The problem with Pritorian XL was not the idea, but the way it was carried out. Now, first I'll tell you the top line, then the problems. About 80% of the 850 patients consented for extended follow-up. That's red flag number 1. The primary endpoint chosen for Pritorian XL was device-related complications. That's red flag number 2. After a median follow-up of 7.3 years, all device-related complications, major and minor combined, were not significantly different in the modified intention to treat analysis. That hazard ratio was 0.73 in favor of the sub-Q ICD. However, the confidence intervals went from 0.48 to 1.12, p-value 0.15. So pause there. The primary endpoint was not significantly different. But now there is a however in the abstract, where transvenous ICDs more often had a major complication or lead-related complication. The authors emphasized the as-treated analysis where patients who crossed over, say, from an SICD to transvenous ICD, then had more complications with the transvenous ICD. The as-treated comparison had a hazard ratio of 0.64 with a significant p-value in favor of the SICD. There were no differences in mortality in the trial. The authors, many of whom I know, and I mean no malice toward, concluded that, quote, the SICD should therefore be considered in all patients without a pacing indication who are evaluated for ICD therapy. The SICD should therefore be considered in all patients without a pacing indication who are evaluated for ICD therapy. My comments. Look, anyone who wants to learn critical appraisal should read the original trial, the letters to the editors, and now read the extended follow-up study in Circulation. There are many important lessons of how bias gets established into the medical literature. Look, the first problem with Pritorian XL is that only 80% of patients consented for longer follow-up. That's not anybody's fault. The authors say equal numbers in the two groups consented, but clearly patients who consent and don't consent for more follow-up are likely different. And it's fine to report on the 80%, but this is no longer a trial. It's an observational study of a select group. The loss of 1 in 5 patients is huge because Pritorian required 850 patients for power, not 500 in this study. The next and most glaring problem was the choice of endpoint. Device-related complications sounds fine, right? But this included many outcomes that could not occur in the SICD arm. Pneumothorax, tamponade, lead perforation. These are primary endpoint events that can only occur in the transvenous arm. This is bad. It just is. Another issue with the primary endpoint was, why use only device-related complications in the extension study? Why not include inappropriate shocks like it was in the first trial? It's not like this problem goes away with the SICD. What's more, additional procedures as a result of the development of a pacing indication or progression of heart failure were not included as a device-related complication. And I would ask, why not? While it's true that these problems are related to disease progression, it's a known problem, like Brady's support, that only matters when you choose a device not capable of pacing. The authors define a major complication as one needing surgical intervention. But clearly changing the device to a pacing-capable device requires surgery, quite big surgery, right? The patient has a new implant in their upper chest and extraction of an old device in their lower chest. That's 2 painful incisions. Also, the authors excluded patients with early or expected battery depletion in the primary endpoint. I think that's a problem because also well known is that the SICD has lower battery life and therefore a need for more generator changes. Generator changes I call harrowing because of their asymmetric risks. So I consider more generator changes as an important endpoint. 11 versus 0 patients in the SICD arm versus transvenous arm had to have an operation for Brady pacing needs. 8 versus 0 in the SICD arm versus the transvenous arm had a change due to a DFT problem or the need for ATP. Finally, I think it's highly misleading to present an as-treated analysis. The authors emphasize that many of the complications in the SICD arm actually happen when they switch to the transvenous ICD. But you should not count these in the transvenous ICD arm as it's done in the as-treated analysis because they would not have had to have the extra operation, the switching procedure, if the SICD had met the needs of the patient, such as Brady pacing and DFTs, etc. Now, there are other problems with Pritorian XL, but this paper is presented as a big trial at HRS. It gets publication in Circulation and will likely be cited in marketing materials for the SICD, but it is fatally biased, and it tells us very little about the choice of device. My final statement I want to make, I am not against SICDs. I'm not against new technology. The problem here is that the SICD, and now actually the extravascular ICD, they may have a small niche role in special situations. I've implanted the SICD, say in a young patient whom you want to protect from VF arrest, but you don't want to burden the patient with 50 years of lead management in the veins. But the problem, my friends, is companies cannot profit with only niche indications, so they aim to expand indications, and it's on us to be careful with critical appraisal and hone our skills for finding biases in studies. All right, final topic is another interesting one. This is about stroke in young people. I continue to be intrigued about the problem when a young person has a stroke. Ischemic stroke is most often a disease of aging. Both atherosclerosis and atrial fibrillation correlate with age. But when young people have stroke, you have to put your thinking cap on. The journal Stroke has published a well-conducted case control study from a group in Finland who was interested in the burden of modifiable risk factors for young onset cryptogenic ischemic stroke by high-risk PFO. Now, they had about 500 patients. These were patients who had stroke, median age 41, half women, and about a third had PFO. Now, they then found controls matched by age and sex. It turned out that it was not so easy to find the control arm. They then reported the association of traditional risk factors like hypertension, diabetes, obesity, smoking, inactivity, etc., and non-traditional risk factors such as venous thromboembolism disease, malignancy, autoimmune disease, inflammatory bowel disease, CKD, liver, and heme disorders, as well as female-specific risk factors such as perinatal conditions or pregnancy itself with cryptogenic ischemic stroke with and without PFO. They then calculated the PAR, or population attributable risk, of these risk factors. PAR is a cool statistical maneuver. It estimates the contribution of the risk factor to the disease. In other words, if you assume causation and then you remove the risk factor, how much disease is prevented? For instance, the PAR for AFib in typical stroke is well less than 20%. And I know it sounds curious given all the attention of AF and stroke, but if you cured AF, if you just wiped AF off the face of the earth, you'd eliminate less than 20% of all stroke. So the main findings of this case control study was that in patients who have cryptogenic ischemic stroke and no PFO, each traditional risk factor increased the odds of stroke by 40%, so odds ratio 1.4. Non-traditional and female-specific risk factors also increased the odds ratio by about 1.7. In patients who had cryptogenic ischemic stroke and a PFO, traditional risk factors played a much smaller role. They increased the odds ratio by only 18%, which, after adjustment, ended up being non-significant. In this case, only non-traditional risk factors increased the odds of cryptogenic stroke, and here the odds ratio was like 2.6. The PAR for cryptogenic ischemic stroke without PFO were 65% for traditional risk factors, and that's a lot. So if a young person has stroke and does not have a PFO, removing traditional risk factors had the biggest contribution. Now, the PAR for cryptogenic stroke with PFO were different. Here, removing traditional risk factors only reduced stroke rates by 33%, whereas removing non-traditional risk factors reduced stroke by 50%. I think finally, one of the most intriguing findings of this paper was that migraine with aura was the most significant contributor to cryptogenic stroke with PFO. Here the PAR was 45% overall, but 55% in females. The smoking PAR was also interesting. It was only 22% for cryptogenic ischemic stroke without PFO, but it was nearly zero for cryptogenic ischemic stroke with PFO. I like this paper. I highlight it because there does seem to be an increase in ischemic stroke in young people. I see this anecdotally, and numerous observational studies support a temporal decrease in stroke in older adults and an increase in younger adults. I take away first from this paper that we mustn't forget about traditional risk factors when young people have stroke, especially without PFO, but also even with PFO. Not smoking, treating hypertension, diabetes, obesity remain important. Second, I think we sort of knew this, but this paper really drives home the message to think about non-traditional risk factors when young people have stroke, especially when there is a PFO. The relationship or association with migraine and cryptogenic ischemic stroke is fascinating. I looked at a few of the citations, and there is much written and thought about regarding why this is. My take is that we don't really know why there is an association. There's things like paradoxical embolism, microemboli, increased vulnerability to ischemia, endothelial dysfunction, posterior circulation involvement are all putative mechanisms behind this association. If anyone has any ideas on reasons for the migraine and cryptogenic ischemic stroke association, please do let me know. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time, write us a review, write a comment. I learn from these. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.